Start then. Yeah. Hi, good afternoon. Welcome to another of our weekly research conference here at the University of Ottawa Heart Institute. And welcome you, our audience, whether located at the Institute or elsewhere or across the country. And so please make sure that during the presentation, you get a chance to ask your questions using the Q&A feature on the bottom of your screen. And they will be answered at the end of the presentation. And we'll also be accepting live questions posed by the participants. And so this will be available at the end of the presentation. And so you can raise your hand or use the hand up feature. And the team will be able to unmute you and allow you to ask the questions personally. And if you have any technical difficulties, please use the chat feature, and our team member will be able to get this resolved for you in a timely fashion. We're absolutely today delighted to welcome our speaker, and that's Dr. Munir Boodhwani. And he's a professor in the Division of Cardiac Surgery here at the University of Ottawa Heart Institute. He's a superb surgeon, and he's also the founder and co-director of the Ottawa Heart Institute Thoracic Aortic Program. Dr. Boodhwani earned his BSc with high distinction from the University of Toronto, and then subsequently medical degree from Western University. He did part of his cardiovascular surgical training here at the Ottawa Heart Institute, and did a research fellowship and earned a master's in medical sciences from Harvard Medical School in Boston. Dr. Boodhwani's clinical interests include aortic valve repair, open and endovascular repair of complex thoracic aortic diseases, transcatheter therapies, mechanical circulatory support, and cardiac transplantation. And his research explores the mechanism of these diseases, particularly in the thoracic aorta. He has to study the preclinical models of aortic valve disease, particularly in terms of insufficiency repair, and also published extensively in the area of aortic valve repair, but earlier also on the topics of angiogenesis and cardiac regeneration. And he has also experience with complex coronary revascularization and also neurological complications following surgery. Most recently, he has co-authored the two Canadian guidelines on the medical and surgical management of patients with thoracic aortic diseases. And for these, Dr. Boodhwani has won multiple distinctions awards. 2017, he was awarded the Heart Institute Global Achievement Award as a world leader in aortic root and aortic valve repair. He also co-directs the Aortic Valve Repair Summit, which is the largest international conference on aortic valve repair in the world. And through leverage of original Oracle research funding, Dr. Boodhwani was able to build a clinical network of cardiovascular surgical investigators across Canada and successfully obtained funding through CIHR project grant competition of over $1.8 million for the Titan SvS trial, which is one of the largest surgical trials funded by CIHR. And indeed, it is on this topic that we are delighted to look forward to Dr. Boodhwani's update on the presentation today, entitled Titan SvS Trial, Rationale and Design of the First Multi-Center Randomized Clinical Trial in Thoracic Aortic Disease. Thank you so much, Dr. Boodhwani.
Wonderful. Thanks so much, Peter, and to the Research Services team for the invitation to present at this forum, and thanks to all the attendees for participating. Before I get started, I just want to make sure you're able to see my screen okay?
Yes, it looks perfect.
Okay. Okay, wonderful. So I wanted to take the next maybe 40 minutes or so to walk through a journey that we've been on for the past, I would say about 5 years or so, in trying to advance the frontier in the area of thoracic aortic disease, which is an area of clinical interest for me, as Dr. Liu mentioned in the introduction. And thanks for that very kind and thorough introduction. Kind of takes me back to old days and reminds me how old I really am. I'll go through a few areas today. The first is we'll try to highlight the clinical problem when it comes to ascending aortic aneurysms. We'll briefly cover what our current understanding is around ascending aortic aneurysms and how it informs our clinical practice. And then talk through a little bit about what made us embark on this particular clinical trial question, how we justified that question to our partners as well as to funders. I'll talk briefly about some of the design considerations, trial design considerations, and some practical issues that we've encountered and sort of where we are in our journey today. And I'm hoping that this opportunity of interaction with the colleagues around the table today, is one where, of course, we get to share a little bit of what we've done, but hopefully we can hear back from you about any thoughts, ideas, ways in which we might be able to enhance the work that we're undertaking. So I'll start with a case presentation, and this is a fairly common scenario that occurs in the clinics in cardiology or in the emergency department or in cardiac surgery. So you imagine a 42-year-old postal carrier who presents to the emergency room with atypical chest pain. This particular gentleman is physically active. He doesn't really have a lot of risk factors except for some borderline hypertension. And he has normal BMI, normal cholesterol status, essentially a normal cardiac exam and normal EKG. But he does have a transthoracic echo performed as part of his workup. And this echo shows that he has an ascending aortic aneurysm. In this particular instance, you can see this is a long axis view of the aorta that shows the aortic root and the aortic valve underneath, and the ascending aorta that's enlarged to 53 millimeters, an aortic root that's enlarged to 41 millimeters. This particular patient has a tri-leaflet aortic valve, no significant aortic stenosis, and mild regurgitation with normal function. And so the question is, you have this asymptomatic individual, what do you do with them? This is a segue into what we actually know about thoracic aortic disease. We know that it accounts for almost 50,000 deaths in the United States annually. That it's a disease that remains largely asymptomatic until a catastrophic event occurs, like a dissection or a rupture. And the ways in which aortic disease is frequently picked up is in the ways that we presented in this case, through atypical chest pain, or often through workup for other problems, workup of a malignancy, perhaps workup of respiratory problems like respiratory infection, and CT scan performed in that context. So most of these patients, if not all, are asymptomatic with respect to their aortic disease. And this becomes an important issue as we talk about the work that we're going to discuss today. We know that mortality and morbidity for patients undergoing interventions for acute aortic syndromes is substantially higher than that compared to elective intervention. And so this makes us think about how we want to identify, perform surveillance, and provide timely treatment to patients at risk. Before we dive deeper into this, it's important to think about what we're talking about. We're talking about really the region of the aorta that begins right at the aortic valve. It includes the aortic root, which it houses the aortic valve and it's the scaffolding for the aortic valve, gives rise to the coronary arteries. And we're talking about the ascending aorta that ends at the innominate artery. And on the left, you see the picture of an ascending aortic aneurysm that we see at a surgical level. I think it's worthwhile perhaps taking a small glimpse into what ascending aortic surgery looks like. So this is a video from an echo of a patient with Marfan syndrome who has an aortic root aneurysm. And when we are dealing with this electively in the operating room, we are essentially resecting that aneurysm. We are examining the aortic valve that's at the base of this aneurysm, ensuring that the aortic valve has good function, and then going through a variety of steps, which I won't go into the detail of, ultimately to replace that aorta with an artificial graft. In this particular case, I'll walk you briefly through the fact that we have to dissect out the aorta from the rest of the structures. We have to remove the coronary arteries in this particular case, and I'll show you that briefly. Here, the coronary arteries have been removed, and the valve sits isolated now with all of the aorta already having been removed. We then use a artificial graft like this graft made out of Dacron that we are going to be implanting instead of the native aorta. In this particular case, the valve is preserved and the valve is reimplanted within this Dacron tube. And you see elements of how that is happening. These are the coronary arteries, which will then have to be reimplanted within this graft. And we've now resuspended this valve, native valve, into a new housing or new Dacron tube. When all is said and done, this is what the final product looks like. The ascending aortic aneurysm that was there before is now gone. It's replaced completely with a Dacron tube. And the purpose here, of course, is to remove the ascending aorta that is at risk of an aortic dissection. So let's talk a little bit about this, the dreaded complication that we're trying to avoid by doing these operations. We are trying to avoid an acute aortic dissection. And an acute aortic dissection is a pathophysiology where there's a tear created within the wall of the aorta, such that it creates a true channel and false channel. And you can see that tear visibly in the CT scan cross-sectionally. And when we look at the aorta in that context, the dissection often arises in the ascending aorta and then goes all the way down to the descending thoracic aorta and down to the femoral and iliac vessels as well. Unlike the aorta I showed you earlier, this type of aorta looks very bluish, it looks bruised. There's often blood clot and hematoma inside the aortic wall. And because the aortic wall is actually torn, it makes for a challenging operation. And I'll show you a brief video to kind of contrast what you saw earlier, and partly for shock value as well. So this is a patient with a type A aortic dissection. In this particular case, you see that the aortic wall itself contains a lot of thrombus, that there is actually separation of the two layers. The outer layer you see right now, and the inner layer you'll see right there where the suction catheter is through. And the challenge for the surgeon in this context is to really recreate a very fragile aorta. And this is an example of the same operation that's been done, or similar operation that's been done in the context of aortic dissection. It takes a lot longer, the mortality is substantially higher, and the outcomes in the long term are not as good. There are other forms of acute aortic syndromes like intramural hematomas, what you see on the left on the CT scan and on the right in the surgical image, where there is a clot formation in between the intimal layer and the adventitial layer of the aorta. And there is no actual tear like the first case, but the hematoma persists nonetheless. And lastly, we see in some cases what's called a penetrating aortic ulcer. These are outpouchings or blisters on the wall of the aorta that have not yet ruptured, but do present the risk of future rupture and are classified along the spectrum of acute aortic syndromes. So the trouble with acute aortic syndromes are that they're a surgical emergency and that there's a high mortality rate if one doesn't intervene on them. It's difficult to precisely indicate what that mortality is, but it's estimated that up to 40% of patients with type A aortic dissections never even make it to hospital. So they make up certainly a proportion of the sudden cardiovascular deaths that we don't completely understand the reasons for. If patients present to hospital, there is the 1% per hour mortality rate from hospital arrival to surgery. And this is perhaps one of the most lethal diseases that one can have. And even if someone makes it to the operating room, they will likely suffer a mortality risk of about 10 to up to 20%, even with current day therapies. And we'll have lifelong sequelae from this that may be stroke or renal dysfunction, and importantly, often a persisting dissection in the distal aorta that is not replaced at the time of surgery. That may continue to grow and will likely require reinterventions in the long term. So acute aortic syndromes in general are highly morbid with a large mortality risk. And when we see patients with ascending aortic aneurysm, our ultimate goal and the way in which we would define success is that we want to avoid this patient having an acute aortic dissection. So this figuratively depicts what we want to do as aortas dilate and aortas present to us with significant aneurysm. We want to get them to surgery, replace and remove this enlarged aorta that is a life-threatening risk to the patient. Of course, the trouble is that any intervention itself has its own risks. So although elective aortic surgery can be performed with low risk, it is not with no risk. And it also has its own mortality risk of about 1 to 2%, in contrast to 20% or so with the acute type aortic dissection. And at the time of surgery, we may be doing things to the valve that may lead to a certain reintervention rate, and perhaps patients may require associated aortic valve replacement. That has its own long-term sequelae. And that has to be weighed against the natural history risk of aortic disease, namely the risk of dissection and rupture that we talked about. And so the decision from the clinician is one of risk and benefits balance, which we do for of course, all our other conditions. But in particular, when patients are asymptomatic, that becomes a challenging conversation. So what do we know about aortic disease and aortas in general? So the first comment is that the normal aortic size is variable from patient to patient based on both the location of the aorta. We see here a normogram of the sinuses of Valsalva versus the supraaortic ridge. That changes based on the body surface area of the individual. It also is different between males and females. As one can imagine, with males having larger normal aortic diameters. When we try to think about what kind of ways in which we can predict who is actually going to have an acute aortic dissection or suffer from an acute aortic syndrome, our biggest data point, the characteristic for which we have the greatest amount of data associating with risk of dissection and rupture, is aortic diameter. And this really stems from studies done at Yale University or by their group in the early to mid 90s and published over a series of publications in the early 2000s. And you can see here that it's a very modest cohort, single center cohort of patients that has driven the literature in this area. They had close to 800 patients. Many of them were kind of a mixed bag of patients with prior Marfan syndrome, some of them having bicuspid aortic valves, some of them may have had genetic aortopathies, and a total of 92 endpoints occurred in these patients. And what they decided to do is stratify the endpoints of acute aortic syndrome, so rupture or dissection or death, by aortic size. And in doing so, they discovered a relationship that as the aortic size increases from, in the 3s to the 4s to the 5s to 6 centimeters, there is a proportional increase in the risk of rupture, dissection, or death, such that a patient with an aneurysm in the ascending aorta of greater than 6 centimeters has approximately a 15% chance annually of either a rupture, dissection, or death. Given this increase with size, and this figure perhaps tries to convey that more clearly, that as size increases, the risk of rupture and dissection increases. A threshold was set to say that we shouldn't let aneurysms get to be 6 centimeters, because patients incur a fairly high penalty for that, and that aneurysms should be operated on perhaps when they're between 5 and 6 centimeters, and a cut point was chosen at 5.5 centimeters. And interestingly, it's really been this data from this single-center cohort that has driven a lot of the early guidelines that have come out around managing thoracic aortic disease in the asymptomatic patient. In contrast, there has been work done through the International Registry on Acute Aortic Dissection. And this is a conglomerate of centers that across North America and Europe that have classified or looked in detail at the way in which patients with acute type A aortic dissections present. So these are not patients with aneurysms, but with dissections alone. And if you look at the mean diameter of the aorta at which patients tend to dissect, that mean diameter is 5.3 centimeters. What that means is approximately half of the patients will dissect at an aneurysm size less than 5.3, and half will have aneurysm size greater than 5.3. Now, this, of course, has critical implications for our guidelines, because our guidelines say don't operate on aneurysms until they hit 5.5. And yet, if we do that, we will miss more than half of the people who are going to have an acute aortic dissection. So while our goal on one hand is to prevent aortic dissections by choosing a threshold of 5.5 and using size alone as our driver, we will miss at least half of the people that are going to have an aortic dissection. Now, I've talked a lot about diameter of the aorta as the driving consideration, but there are, of course, non-diameter related criteria for aortic interventions as well. And although these have been explored in many studies, they have not really borne themselves out to be robust enough to make their way into our current guidelines, except perhaps as suggestions to consider. And so these include the patient's sex, whether they're male or female. There's a suggestion that females tend to grow faster when it comes to their aortas, and there's a suggestion that they have worse outcome. Although females only comprise about 30% of the total cohort of patients with aortopathy. There's a question, of course, around age, patient age, that we factor in. The criteria we use for intervention in someone who's over the age of 80 years old are not the same as what we would use in someone who's 40 years old because of the potential impact on their life, their risks of having elective aortic surgery, et cetera. We consider the family history of aortic complications. We not only talk about absolute diameter, we talk about index measurements, so adjusting for body surface area. We talk about associated symptoms as well as associated conditions like valvular heart disease, in particular aortic valve disease, as well as coronary disease and other things that may be indications for interventions in these populations. And so these are factored in to some extent to develop a tailored approach or personalized approach in decision-making for patients like the one I described in my case. In addition to these, there are a number of characteristics that are I would say, in the exploratory stage. And some of this pioneering work is being done by Dr. Coutinho here in Ottawa around looking at characteristics of aortic stiffness and compliance, and using that as a predictor of acute aortic syndromes in patients who have aneurysms at baseline. There are explorations of imaging characteristics, so not only looking at aortic diameter, but looking at aortic length. That has been associated with aortic acute aortic syndromes. Whether the location of the dilatation, whether it's in the root or the ascending aorta, does that make a difference? Can we get precise enough measurements of wall thickness on imaging studies? And then there are some more novel imaging modalities like 4D CT that can look at aortic wall stress. And the question is whether those types of markers would predict acute aortic syndromes. And lastly, there's a largely unexplored space in the area of biomarkers in trying to predict fast dilatation versus slow dilatation, as well as acute aortic syndromes when they occur. So this is perhaps a rough summary of the state of our clinical decision-making today. And I'll dive into perhaps why a clinical trial is needed now. And I will submit that that's for three reasons. One is that our current guidelines are ambiguous. The second is that we lack high quality data. And the third is that there's clinical equipoise. And let me explore that further with you. It's interesting to note that the first comprehensive guidelines statement on the diagnosis and management of patients with thoracic aortic disease was only published just over 10 years ago. We contrast that to the management of coronary disease or valvular heart disease or arrhythmias. The guideline statements have been there for a lot longer, but it's only in 2010 that the information on thoracic aortic disease was consolidated into a guideline statement. Interestingly, that position statement or that guideline statement made 79 recommendations, and 60% of those recommendations were Class C recommendations, which means they're on the basis of expert consensus based on who's around the table in that committee, with only one Class A recommendations, which is substantiated by data from randomized controlled trials. So this speaks to kind of the ambiguity of the recommendations that we have. And the lack of robust data. Now, in trying to think about this particular clinical question, we did perform a systematic review and meta-analysis, which was published in JAMA Network by one of our residents, Ming. And we looked at the natural history of aortic disease in all of the published studies where patients had been followed with a variety of different imaging studies and also reported clinical outcome over time. And I'll maybe summarize it through this slide. We were able to find 20 studies that consistently reported data on the endpoints that we were seeking. This comprised about 8,800 unique patients and 32,000 patient years of follow-up in this meta-analysis. In these cohort studies, which were virtually all single-center cohort studies and virtually all were retrospective, the mean aortic diameter was 4.3 centimeters. So we're really talking about small aortic aneurysms compared to the threshold I was telling you about for 5.5 centimeters. We found that the average growth rate for the aorta, and sorry, there's a typo in here, is 0.6 millimeters per year, not centimeters, 0.6 millimeters per year. So these are slow growing aneurysms generally. But the risk of complications of death, dissection, and rupture are quite heterogeneous across different studies. So you can see on this forest plot that there are some centers or some studies rather that report a fairly high rate of complication, where some that report very low or almost no complications. With the average rate of complication, or sort of the pooled estimate, is 2.2% per year. So if someone has an aneurysm of in the 4.5 centimeter range, you can say that roughly they have a complication rate of 2% per year. However, you see significant outliers. You see, in particular, the publication by Davies is a strong outlier. Now, as it turns out, this is the publication from the Yale University group, which has really driven most of the guidelines. And in their cohort, they found a substantially higher rate of annual complications compared to what's been borne out in the rest of the literature. And this is really what's been driving the guidelines. So our findings were that these are slow-growing aneurysms, that the risk of complications, linearized annual risk of complications, is actually low in patients with small aortic aneurysms. And this editorial comment on our paper kind of summarizes the sentiment around this issue, which is that although we are embarking on treating a lot of these patients, resulting in a lot of operations, that there's very little data to actually guide this, and that while we may talk about some of the challenges related to doing randomized trials in this type of population, that this has been done, for example, in the abdominal aortic aneurysm literature, and isn't it time for us to do the same? The last point I would make around why a clinical trial is needed now is the notion of clinical equipoise. And so we, in preparation for the trial, did a survey of close to 700 cardiac surgeons, vascular surgeons, and cardiologists to ask them two questions, really. One question was, all else being equal, if a patient is a good surgical candidate of reasonable size, no other cardiac diseases, and has an asymptomatic aneurysm, what threshold do you use to recommend operation? And we found that at least 50% of the respondents reported that they would offer surgery at a size threshold that's smaller than the 5.5 centimeter guideline. And about half, or little less than half, would offer surgery at 5.5 centimeters. So if that doesn't say clinical equipoise, I don't know what does, because we're basically a 50% split between those who follow the guidelines and those who take a more aggressive approach than what the guidelines recommend. Furthermore, the second question we asked was, which of these factors would actually cause you to change or alter your threshold in terms of when you would offer surgery? And so we got a smattering of responses, the most common being bicuspid aortic valves, to say that if the patient has a bicuspid aortic valve, that the provider, the clinician, would lower their threshold for recommending surgery. Interestingly, the latest guidelines on bicuspid aortic valve disease and aortopathy have suggested that the threshold should be exactly the same. It should be 5.5 centimeters unless the patient has certain red flags like family history, rapid growth, or symptoms. So this to us kind of clinched for us that there is sufficient clinical equipoise and sufficient need to embark on this clinical trial. Now, we learned a lot along the way in terms of designing this clinical trial, because it is a unique clinical trial in the sense that it randomizes patients to, on one hand, a very invasive operation, open heart surgery and replacement of the aorta. No patient takes that lightly. That is on one hand, and on the second hand, our inability to predict when complications of aortic dissection and rupture will occur. And thirdly, the fact that the disease is completely asymptomatic, so that when the patient presents and asks us, will I feel better after this operation? The answer is no, you won't. We can say that you might suffer from complications from this operation, but we don't actually expect patients to feel better after an operation. So, it creates a very difficult environment within which to conduct a randomized trial where the benefit is clearly uncertain. The stakes are high, either on the surveillance side, but as well on the surgery side. So the trial design is as follows. The trial randomizes patients who have an aortic diameter between 5.0 and 5.4 centimeters. So this is the zone, what we call the gray zone in surgical threshold for aortic surgery, because that's really where the clinical equipoise lies. The trial design randomizes patients in that 5.0 to 5.4 zone to either have early surgery within 3 months of randomization versus surveillance, which largely focuses on annual CT scan based surveillance, as well as optimal medical therapy in both arms. Our primary endpoint is all-cause mortality, and I'll talk a little bit more about this in a subsequent slide, with secondary endpoints, including incidence of acute aortic syndromes, mortality risk of aortic repair, the incidence of crossover or need for elective ascending aortic surgery in those who are in the surveillance arm, the incidence of stroke in both populations, as that is an important issue that patients care a lot about. In addition, we are looking at some non-clinical endpoints like imaging endpoints, growth rates, quality of life assessments, as well as biomarker assessments. Our sample size is 620 patients, so 310 or so in each arm. We'll talk a little bit about, this slide actually talks about some of the eligibility criteria. So patients who are outside the age range of 18 to 80 are excluded. Patients who are symptomatic are excluded. Those with rapid growth are excluded. Prior cardiac surgery is an exclusion because having prior cardiac surgery increases the risk of subsequent operation. The associated aortopathy in other regions like descending thoracic aorta is an exclusion criteria because that often represents a different spectrum of disease. Presence of a known connective tissue disorder like Marfan syndrome is an exclusion, and a known genetic or inflammatory aortopathy is also an exclusion. On the other hand, who we are including are bicuspid valve patients as well as trileaflet aortic valve patients and the entire spectrum of degenerative aortic disease. In designing this type of trial, we faced a number of issues that we struggled with and actually went back and forth on. The optimal primary endpoint for this type of trial is unclear. We knew that we wanted an endpoint that would be specific to the problem, that would be clinically important, that would be unambiguous in its ascertainment, and that it would be easily measurable. And we went back and forth between trying to decide whether the trial should be powered for acute aortic syndrome occurrence, should it be powered for aorta-specific mortality, or should it be powered for all-cause mortality? And a variety of considerations went into this, partly that if sudden death occurs in this population, often the ultimate cause of death is not clear. And that if we infuse acute aortic syndrome as part of the primary endpoint, that we perhaps bias the group that undergoes surgery because they are no longer eligible or exposed to that particular primary endpoint. We had some statistical kind of challenges around calculating sample size. You can imagine that patients randomized to the two groups would have different early versus late hazards of the primary endpoint around mortality. And while in the surveillance group, you would imagine a constant and linear hazard of achieving the primary endpoint, in the surgical group, you may experience an early hazard related to the surgical mortality, but then a constant and perhaps a lower hazard over the long term of no longer being at risk of an acute aortic syndrome and resulting mortality. So the sample size calculation required support from our methods group, Dr. Wells, in particular, who was instrumental in arriving at sort of the solution for this problem. And lastly, managing crossovers occurring in multiple ways, occurring because patients randomized to the surveillance group might over time grow to the size where they have to cross over to the surgical group. But also importantly, there may be individuals who over time may change their stance. Someone in the surveillance group may say that, I don't want to wait with this 5.2 centimeter aneurysm anymore, and I would like to have surgery. And respecting their decision about their own kind of health goals would lead to some crossovers as well. And lastly, I think given that the trial was looking at a failure time endpoint, we had to create a clear balance between the total patient accrual time as well as follow-up time that would give us sufficient patient years of follow-up to accrue the number of endpoints that would be required for this study. And where we landed on this was a 3-year window of patient accrual with an additional 2 years of follow-up. Although with the current COVID context, this is all in flux. Having struggled through and hopefully address some of the trial design issues, we now struggle with some of the practical issues around running this type of trial. And I'll maybe get into some of these in the next few minutes. When we first approached our potential partners, trial investigators, for an estimate of how many patients they could accrue in this kind of a trial, the responses we got was that we have tons of these patients. In many of these centers, there are aortic clinics that are normally following these patients, and there's so many. But as it turns out, the actual number of trial eligible patients reduce over time, partly because of referral biases that exist in various institutions. Some of these are coming from surgical referrals, so there's an expectation that the patient should have surgery once they've been referred for surgery. In some cases, there are dedicated aortic clinics following these patients, which I think is a great pool from which to draw. And in other cases, we have a mixed bag of clinicians that are following these patients, which include family physicians, internists, and cardiologists, all of whom have different levels of understanding around or different thresholds at which they normally refer patients on. And so a vast amount of educational effort around this trial has been an important challenge. Once these patients do arrive in the hands of potential investigators, there are a number of trial-related exclusion criteria, which I think is, of course, appropriate. For those that meet the trial eligibility criteria, we have learned over time that there are biases amongst the clinicians that are practicing. So there are surgeons who have strong feelings about whether a patient who's 40 years old and has an aorta of 5.3 should really get randomized or should just have the surgery because of the risk that they have of aortic complications. What about the morbidly obese patient? Do you really are they really randomizable for this type of surgery, given that they have added risk associated with surgery? What about adjusting for body surface area, et cetera? And so when you start to think about this, the pool of patients that actually meet the surgeon standards for randomization, that's a much smaller pool than what we would consider the total eligible pool to be. We also run into a variety of patient perception and patient concerns. All of these are very, very legitimate concerns that I think you and I would have if we were facing a decision like this. Importantly, the trial takes away the patient's autonomy about a fairly significant life decision, having open heart surgery. It is clearly a high stakes decision. So on the converse side, people have significant impacts on their quality of life when they know they have a diagnosis, but are not being offered definitive therapy as in one of the arms of the study. There's this notion that often by the time the patients get to an aortic specialist or a surgeon, that they are looking for the expert advice, and they'll often say, I'll do whatever you think is best. But it's difficult sometimes for the clinicians to articulate and for the patients to hear that, I don't really know what's best, and that I'm gonna let this this machine decide through the flip of a coin which treatment you get. There's also this notion that stability is protective. So we've been watching this aneurysm that's been stable for the past 3 years. Why should we intervene now? And the reality is that we have no data suggesting that stability is in fact protective in preventing aortic complications. And lastly, we see a lot of people with intercurrent issues. So patients who come because they were having workup for a lung nodule and now they found an aortic dissection, or they have an active health issue that they're dealing with. And so how does that fit into whether they would be able to participate in a trial like this? Of course, practical issues that we're all facing are the impacts of COVID-19 with suspension of clinical research, the propagation of virtual clinics, which make these kinds of conversations even more challenging, the need for changes in how we manage our study protocols, and an overall reduction in referrals, probably because the number of imaging studies being done has declined also over time. So to summarize and kind of wrap this session in terms of where we are today, this has been close to a 5-year journey now with us. We started with this notion of the randomized controlled trial, which would give us the answer to when we should operate on patients with ascending aortic dilatation. We have now evolved to also include a large registry component. We're realizing that not every patient is interested in the randomized portion of the trial, but many are very interested in participating in the registry. And I think the registry will actually be a very important yield from this entire program and project. Because it can tell us about natural history risk from a multi-center perspective. It can tell us about the risk of complications at various sizes, and it can allow us to think about quality of life indicators, which may be important drivers into patients' decision-making. We have initiated a imaging core lab that's based out of the University of Calgary, who are our primary partners in this trial. And there's a whole arm that it's going to allow us to have core lab CT evaluation to look at growth rate of ascending aortic aneurysms in different subpopulations of the study, as well as explore novel imaging-based predictors of complications that can occur in these patients. And lastly, with the help of our very own Biobank, we are now embarking on making a large kind of biomarker collection of both blood and aortic tissue samples to really explore the space of whether biomarkers can be used for personalized decision-making in this population. A few milestones that we've achieved so far, we were collecting pilot funding from a variety of different programs, including the Oracle plan, including our Department of Surgery at University of Ottawa, and including our Innovations Fund, etc. We were recently awarded a $1.8 million grant from CIHR, so we now have close to $2 million in funding, and now our biggest challenges are to mobilize this funding to actually achieve our outcomes. We have recently activated 15 centers over North America that are formally active and engaged in the trial. We have had 60 patients participate in the study, with 36 being in the randomized arm and 24 in the registry arm. Really important challenges are around getting the centers to enroll their first patient. And once they get into a cadence of enrolling their patients, we see more activity from them. And a last comment about sort of the flywheel effect that's been coined. This notion that in doing this work over the past 5 years, we have had the privilege of working with a lot of committed partners who are individuals who are actually very interested in exploring aortic disease. We have had the fortune of developing a good trial coordination infrastructure here with our own research group, working closely with the Method Center as well as with the Biobank. And we have now the ability to offer pilot funding to different projects. And so we're seeing this Titan vision grow now to expand to potential other critical questions in aortic disease. And so a second trial, which I haven't gotten to today, which is in this pilot phase, is the Titan Commence trial, which compares 2 different surgical techniques, mild versus moderate degree of hypothermia for patients undergoing aortic arch surgery. And another trial that's in its development stage called Titan Head Start, which would compare the types of treatments offered in acute type A dissection. Should a standard treatment be offered, or more extended aortic arch operations be performed in acute type A dissections? And we feel that in creating the Titan SvS structure, we now have kind of the network effects that can hope to have kind of exponential rewards over time. So I'll stop here and maybe take some questions. But before I do that, I just want to acknowledge that this has been a really important journey for the entire team. My partner in crime has been our co-PI, Jahangir Apu at the University of Calgary. Our co-investigators for the CIHR application included Thais Catino and George Wells, as well as imaging experts from the University of Calgary. We have a number of trial or site PIs that are active in a variety of centers that are listed here. We've had a number of funding partners locally that have really gotten us off the ground through pilot funding and enable us to achieve our CIHR funding application success, as well as trainees like Ming, who really wrote that seminal meta-analysis paper that has provided a lot of guidance for the study, as well as our thoracic aortic program here in Ottawa, as well as our research team that's listed there, including our biobank partners. So I'm going to stop here and maybe take any questions that the team may have.
Well, thanks so much, Munir. This is really a titan of an effort and, making a huge impact. And well, one is that, doing surgical trials are, challenging in its own right. The fact that you can actually do randomized trials is already accomplishment on its own. The CIHR funding is really recognition of this tremendous effort. In fact, the fact that you have the network together. And yes, I think you're now on a roll, because now you can actually start the whole Titan family and just keep on going, take over Jupiter and the solar system as time goes on. So there are questions, and so maybe we can, entertain them. So two of them actually relate to the role of family history, and this comes from Jim Robley and also Christine Fitzgerald. And so the question is, how important is family history? And the follow-up, aspect was that I think the known genetic connective tissue specific are excluded from the study. So are there ways to still capture, the natural history of these conditions, which is very much a part of the aortic disease process. Yeah. So I don't know whether you have.
Yeah. Absolutely, absolutely. I think those are great questions. So the first question is around the familial aortopathy. Familial aortopathy is actually a exclusion criteria for the trial, and the reason for that is that our current guidelines suggest that if the aortopathy is truly familial, which means you have a first-degree relative who has a thoracic aortic aneurysm or had an aortic dissection, that our threshold for intervention in those patients should be 5 centimeters and not 5.5. And so by virtue of that alone, they would all hopefully get operated on at 5 centimeters. And so it doesn't enable us to kind of follow their natural history as well over time. However, I can say that in our program, Thoracic Aortic Clinic, the number of patients that have a very clearly articulated family history is small. So I'm going to say less than 10% of the total aortopathy population. Within the familial aortopathy population, the research has shown that only 20% actually have an identifiable gene associated with it. So there's 80% of the population for whom we may think there's a genetic component, we have no idea what the gene is. And there are studies ongoing for that. So really familial aortopathy does get excluded from this. However, there are others who, for one reason or another, may fall in that 5 to 5.5 surgical range or size range rather, but may choose not to participate or may not participate for other reasons. And all those patients are being captured in our registry. So this registry pool, and I think what's going to happen with this is that, our enrollment is as much in the registry as it is in the trial. And so over time, not only will we have an answer to this specific clinical question, but we'll have this large pool of people that we can follow over time and evaluate.
Yeah, absolutely. I think the registry is going to be a very rich source of new information, new hypotheses, really fantastic arrangement. Rob Inez has a very practical question. And Rob says, Quan Chen always taught me the best way to cure a disease is to start a clinical trial. But however, I will say that this has not been true because you are able to actually recruit patients. So it says, Munir, great work and great RCT, but obviously a challenging population. So are there things we can do to help in terms of recruitment or identifying patients or anything like that?
Yeah, I would say two things that are very concrete. So one is that when we see patients like this, to send them on to the aortic clinic, the aortic program, so that they can have an informed discussion about the option to participate. And it may not be right for every patient, but I think that the only way we can get this done is to have conversation with every single patient who is in this size range. And even if they don't enroll in the RCT, we'll have registry data on them. That's number one. The second is, I think that understanding the clinical equipoise and being able to communicate that to the patients is critical, because if patients come with a preconceived notion of what should be done with their disease before they even come to see someone like myself, then it makes the conversation all that much more difficult. And so I think for someone who's following this problem and is referring a patient on for further care, it is important to communicate that this is truly the gray zone, and that participation in trials like this is the way forward in terms of us addressing the issue.
Great, yeah, so very practical. And so there's a question from Lara, who's been working on the aortic valve biology. And so she was interested in that you were collecting blood samples, identifying biomarkers. Are there any markers that's been known or suggest that might be helpful, in this disease? And are there kind of categories of markers that may be helpful, that would be candidates for you to look for with this, sort of biobank? Yeah. Right.
It's a great question, and frankly, I think not a well-defined answer from my point of view. So, the markers that are probably of greatest interest are are markers that are in the TGF-beta pathway, because most of the familial aortopathy genes that have been identified are somewhere along the pathway of the TGF-beta receptor, or sort of its downstream mediators. So I would suggest that perhaps that's going to be the area of the greatest yield. However, this notion of how whether biomarkers can predict either rate of growth or risk of complications is something that's really not been studied, partly because the incidence of complications is low. 2% per year in any population, you have to accrue a very large biobank sample size to be able to even start to evaluate. So I think what the registry and surveillance arms of the study will give us this really well clinically characterized cohort of patients for whom we have crisp imaging data, we have good clinical follow-up, and we have a small number of patients that might accrue endpoints. And I think that will really enable us to do this very preliminary, I think, biobank or biomarker work to start the conversation. I think to answer the questions about what subgroups might be interesting, I think rapid growth is an area that's very understudied, that we don't know a lot about, where I think it would be useful to know which ones stay above average growth of 0.6 millimeters per year versus those that are below and stable over time. And are they biomarker predictors? Because that has impact now on how often you do surveillance imaging in the future on these patients, or do you offer them earlier therapies?
Okay, yeah, comment also from Mark Ruel. It's a great talk, Munir, very instructive and forward-looking. There wasn't a specific question, but I'd like to maybe ask just a last question in view of the time. That is that, like you've done, sort of got the surgical teams together, so if you say, what are some of the pearls of wisdom, I think you kind of scatter them along your talk to a certain extent, in terms of actually being able to launch a surgical clinical trial. And in fact, now you're really gathering the momentum. What are some of the things that are, sort of really essential, to bring you the success that you have already achieved today?
That's a great question. Off the cuff, I would say there are 2 or 3 points that come to my mind. The first is, don't try to achieve consensus. I think when we first started the trial, we engaged a large number of partners and tried to jointly decide on a question that we could all agree on, and then move forward with it. And that whole process lost us a lot of time. And realizing that, all those same investigators who had this, differing views on the issue are now on board with the framing of the question. So, my suggestion is, if you're an investigator with a question, that it's good to move forward in the direction that you think is the most plausible, and people will follow suit.
Yeah.
The second pearl, I would say, and maybe I'll stop there, is find friends that are willing to work with you, because I think this trial would not have gotten off the ground if we didn't have a core group of 5 or 6 individuals who are like-minded and had the will to kind of come along the journey with us. So
Wow, that's really, some words of experience. And yeah, but it's interesting. I guess once you start out with a group of friends, I guess it's been like a social media, and all of a sudden, you have a chance to make a lot more friends.
That's right. That's right.
Great. Yeah. So congratulations again for just a fantastic milestones you're achieving. And of course, it's dramatic presentations as well. All those videos you had, certainly I was watching with bated breath. And so it's just a fantastic presentation and very inspiring. And so all the best, to the study, and keep up the momentum. And also in terms of the additional, projects you can actually garner, as a result of this tremendous effort. So thank you so much for wonderful rounds, and thanks everybody for joining us. Next week is Family Day, and the week after will be a presentation by Dr. Michelle James, who will talk on the molecular imaging of immune cells in the body and the brain. And so this will be an interesting innovation session. So thank you again, and thanks again, Munir. Take care.
Thank you.